Welcome to CardioCon 2022. Myself, Dr. Mukesh Ladha, DM cardiologist from Sal Hospital, Ahmedabad. Friends, we all know that the intervention cardiology has evolved from time to time, and now we are in such era where the imaging has a great role. The Ivers, we all know that the basic tool now in almost all complex angioplasty, including the left main disease. But the understanding and the knowledge in overall the Ivers is the crucial because this is the newer advancement in the intervention and but easy to learn as well. Now, friends, yeah. So as I told that the Ivers is now the main tool to improve overall the precision in terms of the angioplasty, and this is the era of imaging where the Ivers has the great role to give the maximum best result in the angioplasty. Now, what Ivers says, and what normal routine angiography or angioplasty. In routine angioplasty, the vision is our only two-dimensional. Even though we have to work in the whole 3D structure, but we can see only in the two dimension. Here you can see that this picture, you can think about one object, but as you see the 3D image, your whole perception will change because you are totally, change your thought, your mind after seeing this image. So same way, what we see in the angioplasty or angiography, after IVUS, the whole image, the whole perception about the lesion, identification of the overall criticalness of the disease, and later on these background, we decide the treatment, and which is really great helpful to overall prognosis of the patient. Now, coming to the main objective of this talk, as I told you that IVUS, we have a great tool in terms of imaging and identifying the IVUS catheter indicated for the coronary imaging, that we have to understand what kind of IVUS catheter we have and different types of catheter which are available in the market, and these are according to the frequency, and according to that frequency the imaging quality improves. And the next is the recognize how IVUS complement the diagnosis and the treatment. As I told, IVUS is the great tool. It make your decision and make your result very precise and critical. And in terms of IVUS has great role. Now, once you are using the IVUS, what can we think about in lesion terms of that IVUS gives you exact lesion identification, how critical, what kind of lesion it is, and how is the morphology of that lesion. That lesion is having more of fibrous tissue or more of calcium, and according to that, the physiology and according to the morphology of that lesion, we decide the treatment. What are the added modality we have to use when we are using, we are tackling a calcified lesion, that is also can be judged according to the IVUS finding. So in terms of lesion categorizations, in terms of lesion preparation, IVUS is a wonderful tool to start with. Now, the limitation of angiography. Since decades, we are using angiography, and with experience, we know that most of people are very well trained cardiologists, and they do a really wonderful job with naked eye angiography and angioplasty. But once you are added your IVUS, the whole perception will change, as we know that the most of the lesions we see in a two dimension. One dimension can say it is a 30-40, and another dimension it may be 70 or 80%. So these are the view side, drawback of the normal angiography, which can be countered by the IVUS. And IVUS gives you a 360-degree rotational image, which is a total real-time image. Now, so friends, what is the basic IVUS? IVUS is nothing a ultrasound which we used to take inside our coronary vessels with the help of catheter, which is available. And these are the just add-on technique in terms of, we can say, a normal angioplasty. There is no added skill required to learn to incorporate this device in your technique. And IVUS provide detailed and accurate measurement of lumen and vessel size, which is the crucial in selecting the proper size of the stent, and the plaque area and volume. most of the time we just think about the plaque and the volume according to our experience, but this is the IVUS which give you exact objective volume and data about the plaque. And the last thing is the location, the key locations where to start and where to end, that can be clearly demarcated with the help of IVUS. So these are the main purpose of the using IVUS in the coronary angioplasty. Now, how does it work? As I told, this is just a normal ultrasound, and as we use in the echocardiography, the same principle is applied here also. The ultrasound wave which is emitted by the transducer, and ultimately this is reflected in terms of the images, and that images by that software has converted that real world images for our interpretation. So these are the just normal ultrasound mechanics, and that is totally incorporated in this wonderful technique. Now coming to the normal anatomy, when you are tackling with the IVUS catheter and we are going inside, what you found? We know that in our MBBS days that the adventitia is the outermost layer. You see, this is the number one, which is the most outer layer of the vessel wall, and that is the adventitia. And after that, you see the media. This is our target area where we have to deploy our stent and where we have to exactly measure the overall lumen area. And last is the intima. In between intima and the media, the exact is the plaque burden. So friends, as we know the total plaque burden, what is the lumen area, and exact the total length of the lumen diameter. All these three are really helpful to deploy and to select the size of the stent, and that gives you in a long-term better result. Now this is the IVUS catheter. It is a 64 Hertz transducer with digital technology, and which we use in a railroad technique to pass in the normal guide catheter, and that goes into the coronary as in our routine balloon or our any deployable material. Now this is the platinum catheter, because we have different kind of catheter to tackle different morphology and different places to handle. This is mainly used in the peripheral intervention, where we need a bigger lumen diameter, and that can be maximum up to 20 mm. We can see the structure clearly. So these are the main, for just audience purpose, these are the different types of catheter which is used at the different place and the purpose. But they have, the cardiologists are very well aware of these things, and that can be utilized as and when time required. This is again a different type of platinum short tip catheter. That is again, this catheter is a beauty is that beautifully demarcate the bifurcation lesions, where short tip helps in the proper demarcation of the ostial or the bifurcation lesions. So these are the different catheters which are used at the different purpose and different level. And coming to the how IVUS work. With rotational IVUS, we know that the premise of the ultrasound as emitted, and the transducer in a sheathed housing is rotated by a drive cable at almost 1800 RPM. And this RPM is handled by the rotation, which is the governed by the driving cable inside the catheter itself. So these are the normal mechanics which is applicable in our technique. Now this is the motor, basically a motor unit. Through this motor unit, our IVUS catheter is attached, and that motor unit goes in and out. We have to handle by manually that device, and it is an easy to use and easy to handle device, and even a single operator can use whole IVUS thing. And this is the beautiful structure of this beautiful Philips IVUS catheter device and the whole system in toto. And that doesn't require too much big space. You can place in your cath lab anywhere, wherever you want, and it is a mobile also. So this is a good things to do. Now friends, why we need IVUS? Because we want to know the exact lumen diameter. Yeah, we want to know the exact length of the lesions and the plaque composition. as we are handling more and more complex intervention, we want to know the exact plaque composition, how plaque morphology wise, like having more of fibrofatty tissue or more of calcium. And according to that, we have to decide add-on technique or plaque modification technique. And finally, once you are deploy the stent, how good you have deployed, what is the total optimization of stent is the critical thing for final result. And that you can easily detect, or that you can easily visualize with your IVUS catheter or IVUS device. And finally, as we know that whatever you do best, even though even a small mistakes can, totally jeopardize your whole thing. But IVUS, with the IVUS help of the IVUS, you can detect your small tiny dissections also, and that can prevent your major catastrophe or immediate stent thrombosis. These are things really helpful in terms of when you do a more complex or calcified intervention. And this is the normal, A is the normal anatomy of the coronary vessels, and the B is the where lesion is there. And according to that, you have to judge the total luminal area and the maximum luminal area. And this is the normal math which is used to identify the exact lesion, the size of lesion, the plaque burden, and on that basis we have to judge the stent size. And this is the really a wonderful thing, so that you can minimize your geographical mismatch, even though with the axial geographical mismatch as well as longitudinal geographical mismatch. Most of time we have, when you do naked eye or two-dimensional angiography or angioplasty, that time most of time this may happen because you just sometimes you undersize the stent mostly, and that prevent your that delay your overall problem. Now, coming to the different kind of plaque morphology, where what kind of morphology you see in a IVUS. The fibrous plaque, first slide, the left side, that fibrous plaque that is more homogeneous, that you can see easily whole the structure homogeneously placed. The second is the calcific plaque. You see that more brighter structure almost at 12 to 2 o'clock, that is having more calcific plaque. So these are the basic things to understand while you do IVUS. The soft plaque rupture. You see that there is a plaque rupture that most of time when patients, even the young population, when the plaque burden is not more, main pathology is the plaque rupture or plaque erosion, that can easily detected with this IVUS. And the last is the dissections. Most of time when you do intervention, you don't know which is the true lumen or which is the false lumen if you created true, false, true. But in that case, you, with the help of IVUS, you can easily recognize which is the true lumen and which is the false lumen, and you can detect your dissection at timely. Now, this is the last slide. As I told that IVUS is having a wonderful role in the coronary as well as in the peripheral intervention. People who are doing complex peripheral intervention, that time also the same indications can be applied for the peripheral intervention, selecting the proper armamentarium, proper stent size. All these things can be managed with the IVUS catheter. We have integrated Philips overall IVUS, where you can place your whole things on your table, and you can place your screen alongside your 2D angiography image. And this is the seamless integration. You need not to carry your whole console or whole things in toto, because and this is the main beauty right now, because it is easy to handle, easy to see, and these are all things are in side by side. So this is the great advantage when you are using this seamless integrations. And this is only platform with the supporting Windows 10 and the most secured platform, and 24/7 online support. Whenever you require support, they have persons who can immediately help you solve your all problems. And this is the system capable of all peripheral as well as coronary applications. So this is the real tool when you are doing all kind of intervention, and a wonderful thing. This is the just prima facie of the seamless integrations, where you can see the whole screen which is attached to the cath lab itself, and this is the cath lab all normal functioning buttons, and this is the attachment of the system to the IVUS screen itself. And now same thing, this is the inside cath lab, where the whole monitor is attached to whole screen, where you can see your coronary angiogram as well as IVUS images both same time in real world. And this is the again outside the console, where you can see images, you can show to your patient also, as well as you can also interpret it after doing your angioplasty. So this is the overall good integrated system, where you can place your working screen alongside your angiography screen, as well as you can do study later on when you require outside the cath lab inside your console. So wonderful things, and the new intervention, a new invention in terms of IVUS. When we used to in the initial era, when we used to see whole system in a one tool, but now it is totally integrated with our cath lab. So it's a great thing. Now, different kind of IVUS modality is available to analyze proper physiology and the vascular structure of the coronary and other peripheral structure. This is the digital IVUS, where we used to do normal coronary intervention, and this is the chromoflow IVUS, where we can easily identify the maloppositions or how good is the stent opposed to the vessel wall, because once it can detect the blood flow which is going only through the lumen. If it is going between the lumen and the stent, then we can see that stent opposition is not proper. So it's again a great advancement in this Philips IVUS. And this is the peripheral IVUS, where the same thing which we do in the coronary, and this is the high resolution, because the 45 megahertz catheter, which gives really equivalent image to any other or advanced IVUS catheter, IVUS device. And the last, which is again important thing, is that this IVUS catheter comes with IFR, and this is the really boon when you are doing or judging the vessel where borderline lesion is there, when your decision making doesn't fulfill with only IVUS, and that time IFR play a great role, because the physiology is the main thing when you are taking any decision, which sometimes in the situations like IVUS may be plus minus, but with the help of IFR, you are 100% sure that you go for the plasty or not. So these are the integrated things which gives you a lot of comfort in terms of making a decision. Now, friends, this is the digital IVUS catheter. As I told, that this short tip catheter, these are the different type of catheter, and among them, this is the short tip catheter, which gives you a good result in terms of side branch ostia and the total assessment of the bifurcation lesion, mainly in the coronary left main system, not left main bifurcation. So this is the new thing. And now the chromoflow. The chromoflow is the such thing. It's kind of an invention in terms of the physiology of the overall the coronary, where we can see the incomplete appositions with the help of this chromoflow. Where if suppose the blood go in between the whole lumen, that means your stent is totally purely apposed properly, and there is no malapposition. So another way of looking your vessels from the inside with the help of colors, which gives you another way of thinking about your vessels and the stent. This is the lumen, where you can see incomplete appositions. You see the stents are not apposed properly to the media. And after that, you can see the tear also. Here you can see that there is tear in the vessel wall, where the blood is again leaking from that part. So these are the benefit of the chromoflow, where you can see sometime a hidden dissections which you can't see with your naked eye, but that the technique and that image that can show you. Now this is the whole thing can be done through the radial access, That also gives great comfort to the patient, and as well it is the highly resolution, the frequency which now we are getting the 45 megahertz, which gives you a comparable image quality to any any imaging other tool. And the next thing that this Philips device doesn't require a disposable sled as and when you go for a next case, and this is the mostly control with automatic pullback device. It doesn't require like in the you have to change that thing again and again when you are going for a next trip, but this is the thing which you can use as many time as you want. Coming to the peripheral intervention, here we can see the role of Ivers in the peripheral intervention. The same way as you do coronary intervention, the similar way you can use Ivers catheter, because this Ivers catheter can see up to 20 mm diameter of the vessels. So you can do your plasty in the leg vessels or in the calf vessels, where they give you better understanding about the lesions and the proper positions of the stent. So not only in the coronary, these IVUS device can use in the peripheral system also. Now coming to the IFR. We know that IFR is having a great role in terms of decision making when physiology has a game changing, basically the deciding factor when you want to do stent or not. And this device, when integrated with the IFR, and gives you an extra added comfort when you want to take a decision. Now IFR co-registration. This is again a new thing, and I'm really glad to share with you guys, because this is just a virtual stenting. Before doing angioplasty, you can identify that these are the area where you are going to get that much of IFR before deploying the stent, and this is the real thing where you can judge, or where you change or you can manage your plan according to that IFR readings. So it's a great thing. An integrated approach, decision making makes your decision making very easy and clear cut, and it's really mesmerizing things to do when you do angioplasty with such system and such kind of technique. Really help your patient to do better in future. Thank you so much, dear.